Let's go ahead and get started. Welcome to the August National Pilot Webinar. Let's see if my screen is working. Just a few housekeeping as always. Please mute yourself. We have two presentations today. This is an open forum like discussion, but please mute yourself while the speaker is speaking. And but then when we open it up to questions, feel free to unmute yourself to ask your question, or you can type it in the chat box. These meetings are recorded and they will be posted on the NBSCRN YouTube channel. Here's our agenda today. I would like to first start off and open it up. I see that Angela's on the call. Angela, I wanted to see if you wanted to just say something about the lab director, Bonnie.
Thanks, Jennifer. I'm not sure if everybody knows, but Bonnie was our lab director here in Georgia over the past year, and probably even had a bigger impact with the newborn screening program in Florida as well as in Michigan. Unexpectedly passed away a few weeks back. I think we're all still reeling from this surprise. I wanted to make sure everybody knew, but also to share all the share my gratitude for all the love, the support, everybody's outreach and love on that has been really kind and really generous. And I know her family would be grateful to know that that the newborn screening family loves her as well. So thank you, everyone.
Yeah, I just wanted to add, Bonnie was a great contributor to the newborn screening community and attended these calls, and she will be greatly missed. So thanks, Angela, for bringing that to everyone's attention. So switching gears, I just wanted to first introduce our first presenter to the call. Hold on one second. I have to see my screen. Our first presenter will be Dr. Holly Piet. Dr. Piet is the director of the newborn screening program and is the Early Check newborn screening program, and is a senior research scientist at RTI International in the Genomics and Translational Research Center. Dr. Piet received her bachelor's degree from the University of Virginia in biomedical ethics, her master's degree in genetic counseling from the University of South Carolina School of Medicine, and her doctorate degree in medicine from Leiden University in the Netherlands. She's board certified in genetic counseling by the American Board of Genetic Counseling. The focal points of her research are the psychosocial and behavioral impacts of emerging technologies and approaches for their ethical applications. And Dr. Piet will be speaking today about the Early Check Newborn Sequencing Project. So with that said, I'm going to stop sharing my screen and hand it over to Dr. Piet.
Thanks, Jennifer. All right, I'm going to try to do this presentation in Teams because PowerPoint has died on me for some reason. So hopefully I'm going to be able to advance these slides. Can you see the slides correctly? Are they in the right mode?
Yes, we can.
Perfect. Okay. Well, thanks for that introduction. I'm really pleased to talk to you about the Early Check program. I'm going to do a very high level overview because I did want to make sure we had time for discussion, but if there are any details folks would like, I'm looking forward to digging down into some of those details in the discussion period. So a couple of disclosures: we do have a public-private partnership that funds Early Check. Our current funders are shown on the screen. We have historically had additional funders too that helped us set up Early Check, including NIH awards. And we're very lucky to have many different companies and organizations that have been involved in making Early Check a reality. So some of you have heard about Early Check before. We've talked about Early Check on some of these calls, and I'm going to talk a tiny bit about the history, but then spend most of the few minutes we're going to have discussing Early Check on talking about our new work that we're about to launch. but we have the benefit in this study of having an ongoing research program that started in 2018. And we've been screening newborns in North Carolina. This is a North Carolina specific program. Since then, have historically gone condition by condition. And again, you'll have heard a bit, some of you heard a bit about some of our pilot programs in spinal muscular atrophy, Fragile X syndrome, and Duchenne-related muscular dystrophies. We have, because our recruitment is across the entire state, we've had to be quite pragmatic in developing and implementing approaches for large-scale research. And North Carolina is a diverse state in terms of sociodemographics. We have individuals who are, in quite rural areas and quite urban areas, but we also benefit from having many strong universities in the state. So we've had to develop an approach that allows people to make an informed choice about participating in a large-scale research study, and have done that through approaches like adaptive informed consent that allows people to provide informed consent electronically. We do lots of different kinds of outreach. Most people who come to Early Check are not recruited in person, so they are also recruited virtually or through a letter. And actually, since most people screen negative, they also get their results through the Early Check portal. So for the large majority of our research participants, unless they initiate contact with us, and we try to make it very easy for them to do that, but unless they initiate contact with us, we actually don't have a person-to-person engagement. The engagement is virtual. I mentioned before the importance of living in a state that, or the benefit of living in a state that has a lot of very strong academic and medical facilities. We are, our Early Check is housed at RTI International, which is a independent research group that does not actually provide clinical care. So we coordinate and organize the Early Check program, but we work very closely with academic medical centers across the state to implement the program. And one more very important collaboration is that we collaborate with our state laboratory, and we actually do that for a number of really critical reasons. One is that Early Check is intended to test different models and approaches and screening techniques for the potential for future integration into public health, and to make sure that we do that most effectively and efficiently and feasibly. We work very closely with Scott Schoen and his team in North Carolina so that we can scope and produce appropriate data that is useful for the state. But we're also able to use the residual dry blood spots for our screening, which reduces a lot of the barriers for participation in Early Check that would otherwise be there. We've currently enrolled almost 27,000 newborns. So again, this is large scale research, and we have quite a bit of data about how we've done so far, and we're using that data to inform a next step. And that next step is intended to help answer some of these nuances that are facing the both public health as well as clinical care as new technologies come available. And those technologies are both in terms of laboratory technology, so our ability, for example, to use sequencing, which is what we're moving toward, to identify hundreds or thousands of conditions with a single blood spot, but also the fact that we have technological innovation that is fueling therapeutic development. And so we have many, many therapies that will become available within the foreseeable future for a wide array of rare genetic conditions, and even for common conditions. And so we're trying to prepare the system by providing data, giving resources that we're testing in our project, and testing infrastructure and things like SOPs and follow-up procedures, so that we as collectively as a community can make good decisions about whether and when new technologies should or could be integrated into public health. So to do that, we're going to be adding, and soon we expect by September to begin screening, two panels, large sequencing panels to early check. One of them is for highly actionable conditions that look quite like the conditions that are already part of state newborn screening, in that they're highly actionable and actionable very early in life. We're offering parents the option to add a second panel of conditions that are for conditions that are less actionable, but that we still feel confident we can provide something to families in terms of intervention, surveillance, or even the option to participate in clinical research and clinical trials. And we're also pushing boundaries a bit by offering parents a risk score for type 1 diabetes, a genetic risk score that is not a yes or no answer. It gives people an indication of whether an infant might be at a higher lifetime risk than the general population for type 1 diabetes. So both of the sequencing panels, really all of those options, panel 1 and 2, and the genetic risk score is built on a genome sequencing backbone. I mentioned before that the first panel is highly actionable conditions. We are including the core RUSP conditions that our state is screening, which allows us to do some interesting comparisons between the state developed results and our results in the early check program. And we have a careful plan that we're developing and implementing along with our state to make sure that we're clearly communicating the potential for this to happen to our participants, and also providing effective education and genetic counseling should it happen. As well as I mentioned, conditions that look like newborn screening conditions in terms of actionability and age of action. And I already mentioned that we also have a second panel. So we set our original aims in terms of a 3-year increment because that's what our current funding is, although we certainly hope and plan to extend this much longer. We, as I think I mentioned before, our study is very pragmatic. We are really leaning hard on implementation science approaches and outcomes to look for feasibility and barriers to implementation. And so our aims are quite focused in that direction. Our first aim is to implement and evaluate genome sequencing for up to 10,000 newborns for those 2 different panels of conditions. We want to know whether people want this and why they want it and why they don't want it. So we're looking at uptake and acceptability. We're going to implement and evaluate those follow-up procedures so that we can inform future public health application. And we're going to assess 12-month outcomes, both for infants, but also for their families, to see both are we doing something positive in terms of the baby's health, but also are we doing anything disruptive to the family, and or are we able to provide them with more sort of empowerment and utility in receiving those test results. And for type 1 diabetes, similar, although because this effort is more novel, we're actually starting with an aim that we've actually practically completed at this point to conduct a lot of formative research among different stakeholders in the state to understand their attitudes and perspectives about offering this different kind of information in the newborn period. But similarly, we're going to implement a pilot that, like I said, we're about to launch and look at acceptability and uptake and assess 12-month outcomes. This is an example of a piece of material. We work very hard in early check. We believe in doing a lot of formative research, evaluation research, and stakeholder engagement. So the materials we develop are informed by many different voices in our state, and then evaluated amongst people who agree and decline early check participation. And this work is really only possible because we have a very large and quite able team who can bring many different kinds of skills. And we have, as I mentioned, a very excellent clinical collaborator at UNC Chapel Hill, collaborators at UNC Chapel Hill, and of course, our State Laboratory of Public Health. With that, I'm going to stop sharing and hand it over to Ingrid. Well, I guess back to you, Jennifer.
Thanks. Thank you, Holly. I'm going to pause and see if we have any immediate questions in the audience before we move on to Dr. Holmes' presentation. Do we have any questions? Feel free to either unmute or raise your hand. Oh, Dr. Holmes has a question. Go ahead.
Yeah, no, I just have a question. So I'm also an endocrinologist, and type 1 diabetes, the average age of onset is like 13 years. And occasionally we get kids that are, 2 or 3 who develop it, certainly, but it's a much more of a long-term kind of thing. Like, what are your thoughts about, kind of when you look at outcomes for type 1 diabetes in particular? I mean, for a lot of these, you need longer time period, but particularly that one. Yeah. I mean, are you or are you not really looking at if the person develops it and the impact on them? Are you just looking at kind of doing the screening? What are your thoughts about that?
It's an excellent question, Ingrid. So we are hopeful and positive about our ability to follow these children longer. But again, no one funds a program for 12 years. So it was
Right.
just not feasible. So one of our funders, as you may have seen, is what used to be called the Juvenile Diabetes Research Foundation, which is now JDRF. And we have worked hard with them and a expert advisory committee to develop a plan for following those children if our project is not funded in perpetuity.
Right.
One of our objectives is not to test the validity of that polygenic risk score. We're actually hoping to do that in another population, but that is not going to be something we can do in our population because we're not going to follow people over life. And, we're not doing a longitudinal study in that long-term way. But what we offer through our study is people who have hit a particular threshold for that polygenic risk score. We provide autoantibody testing, and that, for people who are unfamiliar with type 1 diabetes, that is a biomarker that is indicative of future onset of type 1 diabetes. And we're doing one. If there's a positive, we provide them a second one within our study. And then we have a pediatric endocrinologist who is part of our study group who will see those children, and we will offer them resources for additional autoantibody testing, and importantly, do education for their primary care provider, so that primary care provider understands what that child would need over time, because once they have 2 positive autoantibody tests, they're quite likely to convert to type 1 diabetes.
Yeah, though again, they don't develop that really in the first year probably, but they would develop it. I mean, so you're kind of setting up a follow-up program for the kids who are positive.
That's exactly right.
Yeah.
Yes.
Do we have any other questions? Since we have a busy agenda, I'm going to move to the next one. Holly, are you able to stay on until the end of the call?
I can. Yes.
Okay, so please, if you guys have any questions, please type them in the chat, and hopefully she'll be available to answer them after Dr. Holmes' presentation. I'm going to go back to my slide if I can. There we go. Can you guys see it? So our next presenter is Dr. Ingrid Holm. As she stated, she is a pediatric geneticist and endocrinologist. She has broad experience in basic science research, and clinical practice, and her major research area is on the ethical, legal, and social issues related to the impact of return of genomic information to participants and families. She's co-PI of 3 projects, including the Newborn Sequencing and Genomic Medicine and Public Health, or INSIGHT project, as well as the genomic sequencing-based screening for childhood risk in newborn illness, which is also known as BabySeq. She actively participates in the INSIGHT Ethics and Policy Board, which puts forth recommendations regarding the integration of sequencing in the newborn period. She is currently the co-chair of the NBS-TRN Steering Committee and the co-chair of the NBS-TRN Bioethics and Legal Work Group. And she did give a presentation, I believe in January of this year about BabySeq-2, and now she will be providing another presentation about BabySeq-2 implementation of whole genome sequencing as screening in a diverse cohort of healthy infants. So with that said, I'm going to stop sharing, and Ingrid, I will hand it over to you.
All right. And you can see my screen, presumably.
Yeah, we can see it.
Okay, great. So I'm going to, so as Jennifer said, the initial BabySeq project that I've actually now, that's in the past, it's a co-PI on, I'm going to talk a little bit about, and then about this project. And since I did talk about this in January or February, I'm going to kind of review it and then just give a little bit of some kind of updates about it. So the BabySeq really addresses the kind of limitations of newborn screening, where there's a lot of, I think as kind of Holly mentioned, there's a new time-sensitive gene-targeted therapies that are being developed, but the process right now to add a condition to the RUSP is very slow, and thousands of other conditions could be screened for simultaneously if we use genomic sequencing. And so if genomic sequencing were part of newborn screening, not only could we screen a lot of conditions, but it would allow for this early intervention for children with treatable or preventable diseases. And even in those with non-treatable diseases, this would potentially eliminate the diagnostic odyssey that I think as geneticists we're very familiar with. In addition, as soon as a genetic condition met the criteria for newborn screening, it could be added the next day if you just had the sequence had the ability to do that. So it wouldn't take, 13 years and waiting for a committee to add something. You could really add it kind of right away. So the BabySeq project is really designed to examine the clinical utility and the impact of genomic sequencing in newborns. And so we're looking at the medical impact on the individual and public health, behavioral impact on physician and patient behavior, and the economic impact on costs for the healthcare system. So the goal is to explore how genomic sequencing could be incorporated into newborn screening. And I think one of the kind of differences of BabySeq is really looking at the return of results for any pediatric condition. And so this is slightly out of date. There's more than 73 genes on the ACMG, but the point of this is that the RUSP has a limited number of conditions. The ACMG kind of list is limited, but BabySeq is looking at over 1,000 conditions. And so again, I think what Holly was talking about is kind of focusing on treatable, really a focus on treatable conditions. And we're really looking at everything, even if it's not treatable, but it's of childhood onset. And so this kind of sets our study apart from other studies that are looking really only for actionable conditions. And this just kind of, shows you kind of the buckets. So if a condition is of childhood onset with strong evidence and high penetrance, we would return it. It was moderate evidence of penetrance, but was actionable, we return it. But if, with the exception of 2 adult onset conditions that are on the ACMG list, we're essentially not returning adult onset only conditions or conditions of limited evidence or low penetrance. And we're really focusing on pathogenic and likely pathogenic. We're not turning VUSs unless there's a particular indication. So if a baby has a particular condition, a seizure disorder, for example, we would kind of do a deeper dive as an indication-based analysis and potentially return VUSs. But for the screening test, we'd only returning pathogenic and likely pathogenic variants. And then we're looking at parental and family outcomes, so psychological impact on the parents, the effects on parent-parent relationships, and the effects on parent-child relationship, really kind of looking at bonding. And the BabySeq, initial BabySeq project was very focused on this because we're very focused on looking at the potential harms as well as benefits of newborn screening. At the time that we started this project, which was probably almost 10 years ago, there was a lot of concerns that there may be harms to families. So we enrolled over 300 babies, 159 of them were randomized to get sequencing. And we found what we call a monogenic disease risk, or MDR, in about 11%. And this is just a list of what the conditions are. And it shows you here kind of if there was phenotypic evidence. So you can see for 4 of them, there was phenotypic evidence. There was a family history for about a third of them, and there wasn't really any phenotypic evidence in about a third of them. And of note, one of them was a child with biotinidase deficiency, which is on the current newborn screen RUSP. And then we looked at parental responses and basically found that there was no, here we're comparing, I should say, controls, people in the sequencing group, and then those who had a monogenic disease risk. And there was really no increase in parental depression, and all the scores were as well below the cutoffs for depression. The same with parental anxiety, parental self-blame, and parental perception of the child and relationship. And so we really in this cohort did not see any kind of harms of doing this sequencing. And then as part of the project, we put all of our data into the MBS-TRN LPDR, so the longitudinal pediatric database or data resource. So this now has all of the phenotypic and genotypic data available for use if other people want to kind of access this data and use it for their own studies. So the issue with the BabySeq project is that almost all parents who enrolled were non-Hispanic white. And so we approached families in the Brigham and Women's Well Newborn Nursery, as well as the NICU at the Brigham and at Children's. And these are very diverse. The NICUs are very diverse, have a very diverse population. The nursery had a very diverse population, but those people who chose to enroll were really almost entirely non-Hispanic white. And so this led us to the kind of the BabySeq 2 project, which really addresses this lack of diversity. And so when we think about kind of diversity and enrolling populations that are underrepresented in research, the concern is distrust of research in genetics among these among underrepresented minorities. And the bottom line is, if genome sequencing is to be offered as a component of newborn screening, it's really crucial that individuals from a broad range of ethnic and racial backgrounds are engaged in the research that will inform how we can do this. So it really is important to try to enroll a really as diverse of a population as we can. So this is a BabySeq 2 project. It's a UO1 that's funded by NCATS. And we have 3 main clinical sites that are part of the grant. So Boston Children's Hospital, Mount Sinai, and University of Alabama. We also have 2 kind of clinical sites that have wanted and have become now part of it that are kind of outside the grant. So Children's Hospital of Philadelphia and Corewell Health, which is in Michigan, have kind of joined us. We have an economic analysis that's being done at Harvard Pilgrim Healthcare. The Broad Institute is doing the sequencing. And Baylor College of Medicine is really involved in the kind of surveys and looking at parental outcomes. So BabySeq 2, like BabySeq 1, is a randomized controlled trial of whole genome sequencing. And so our plan is to enroll 500 healthy individuals, healthy infants between 0 and 12 months of age, and their community pediatricians, focusing on African-American and Hispanic infants. And then either they'll get kind of standard pediatric care, which will include getting a family history and analyzing that, or doing the same plus genome sequencing. And then the results are disclosed by a genetic counselor and a research system to the families. The results get sent to their pediatricians, and then we're looking at the medical, behavioral, and economic outcomes. And so when it comes to kind of enrolling diverse participants, we realized that we had to really go to where the potential participants are. And so we're enrolling through community health centers that served underrepresented minority populations. And so we realized that this is not enrolling in the strictly newborn period, but the only way to really enroll these diverse populations is to go to where they are. And so even though we're looking this from a newborn screening lens, we are enrolling kids who are a little bit older, but still within the first year of life. And so the enrollment sites include Boston Children's, which has a clinic called CHPC. It's actually CHPCC. It's kind of a big acronym. But anyway, it's really mostly African American and Hispanic families from a low socioeconomic status in the Boston area. Mount Sinai Pediatric Associates, which again is primarily African American and Hispanic, and the University of Alabama, a clinic called the Children's of Alabama Primary Care Clinic, which is primarily African American. So part of this study, it was important as kind of working with more diverse communities is an important piece of this was a community engagement. And so we approached that in really kind of in two ways. We're doing or have done parent interviews. So basically enrolling parents who are parents of children who are taken care of in these clinics, who have young children, obviously, and asking them about their kind of beliefs about genetics, experience with genetic testing, what kind of barriers they would see to participation, concerns about the study, types of information they want to hear about, and what kind of outcomes and test and study results would be of interest. And so I'm going to show you just a couple of things that they said, but we've done those interviews and now kind of putting that data together. But that has really helped us kind of think about what the community is thinking about enrollment. And then we have originally called a stakeholder board, and now we're calling it, or have renamed our community advisory board. So this is a board of members who are parents at, again, all the 3 clinical sites. It's about, I think they're about 10 parents altogether. And so we meet with them 3 or 4 times a year for about 2 hours, getting their perspectives on genetics and research. And they've really helped us guide the protocol development, the participant research procedures. They've helped us think about challenges in implementing and enrolling. They've also been very helpful in terms of things like the consent form. And so they really have provided a lot of significant input that has actually made a change, led to changes in how we're carrying the study out. And we're also giving them the option and to partner with us in writing up findings and publications. And they already have been involved in our marker paper. And also there's at least one member of the board who's a co-author on the paper about parent interviews. So this is just a parent interview. So at the 3 sites, we did 20 interviews, and you can see that it was actually, they were all female, combination of African American, Hispanic, and white. In terms of ancestry, we did 5 of them were in Spanish. Most of them was a variety of kind of levels of education, and most of them of these families were making less than $50,000 a year in terms of household income. And I'm just going to show you kind of some, we have a lot of data from here, but just some of the things they said about motives for enrolling BabySeq. So things like early knowledge, the importance of early knowledge. So if you know about it early, there could be ways to treat it or even maybe avoid it. And I think the power of knowing beats the power of anything else. Preparing for the future, I could be prepared so that we would be aware of like what to expect so it doesn't catch us blindsided. And managing non-actionable information, because if you know the child has a condition and that he's going to die, and you would try to give him a better quality of life for as long as he lives, right? And then in terms of acceptance, if it's really bad, I definitely want to know, and getting it at a young age is probably a nice time to start the accepting process of what's not going to change. So it's kind of interesting to kind of hear what people have to say, particularly of conditions that may not be actionable. And we have a lot more data on this. And as I said, we're putting it together now for publication, hopefully this fall. And so this kind of led to our study design. So again, we're enrolling infants 0 to 12 months and parents 18 years of age or older who are either English or Spanish speaking. They do a baseline survey, and we get a 3-generation family history at enrollment. And then once they've enrolled, we randomize them 1-to-1 to either just getting the family history back or the family history plus getting genomic sequencing. We only collect samples for DNA from the infants in the sequencing arm. And this really was something that came from our community advisory board, who told us that if you draw blood from a baby and then you don't use it, parents are not going to be very happy, and they're not going to really trust you. You know, you're taking my child's baby and you're not using it. And so that was an example of something that we changed based on feedback from our community advisory board. Then we're doing sequencing, CLIA, whole genome sequencing at the Broad with analysis at the Laboratory for Molecular Medicine here in Cambridge, and returning results to both arms, either just the analysis of the family history report or the family history report plus a genome sequencing report. And if there is a finding, we offer families to be sequenced, 2 family members to be sequenced to look for that variant. Because family structures are not necessarily mom, dad, and both biological that the child is living with, we're not doing trios because that would really limit our, if we required there to be biological parents, it would kind of limit our enrollment. So we're just focusing enrollment on the babies and offering sequencing if there's a variant of interest to family members. Then we have a sequencing report that has risk for childhood onset and highly actionable adult onset conditions, carrier status for childhood onset conditions, and some pharmacogenomics that are relevant to pediatrics. And then, as I said earlier, if a child has a particular condition, we'd do kind of a deeper dive into that genes related to that condition. And this is just an example, just to show you that we have the sequencing report. It's kind of divided up into a childhood onset condition, adult onset, just those 2 conditions, and then the childhood onset conditions with the lower penetrance. And the example here is atypical hemolytic uremic syndrome. And then there's a second page that just goes into more depth about the findings that's more geared towards the primary care provider. And then we get a family history, and then have a report that we kind of divide up into conditions with a possible genetic cause and conditions that are kind of a gene environment or multifactorial. And so we kind of talk about those separately and return this information to families. As part of this study, we're offering enrollment to healthcare providers whose patients may be enrolled in the study to give them some kind of genomic education. And this is done by Hudson Alpha, which have a genomics education program that's modified from the South-Seq project. And we're using some didactic videos and training sessions and to give them information about the content of reports, what to do with the results, and how to counsel parents. And we really are inviting all healthcare providers in the clinics where we're enrolling to participate in this intervention. And what we found from this intervention is that this just shows knowledge. This first one, so blue is before and orange is after. So we certainly see an increase in knowledge after going through the education. And then the panel on the left here is confidence. So the top one is not confident at all. The second is a little bit confident. And then the panel on the right is after the training. We can see that it really, the confidence level of the physicians or providers who took this really increased significantly after going through the training. And then we're doing surveys at baseline right after disclosure and at 6 months in both the groups, and looking at the same things we did in BabySeq-1. So disruptions to the parent-child relationship, to the parents' partners' relationship, and to personal distress. And this just shows some of the measures that we're using for that analysis. And then we're assessing, of course, the medical impact on the families by reviewing medical records. We'll be in patients who have findings, we'll survey the families to track the symptoms and really just figure out or understand whether the finding reveals an unsuspected phenotype in the infant or family, explains a family history of a condition, or prompts surveillance in the family. And then we're going to collect data also from the healthcare providers throughout the study on the impact on the study, and then through interviews at the end. And this just summarizes kind of our healthcare utilization and costs, which we also did in the initial BabySeq project to look at services utilized in the child and in the parents. So I thought I would just give kind of an update. We've been enrolling for about 6 months. And this just shows the number of families that are approached at Boston Children's, Mount Sinai, UAB, and Corewell Health. And then the number who have enrolled in terms of signing a consent form. We're finding that even like people sign a consent form, even though they're enrolled, not all of them continue to do the surveys and get samples done. So it's realized that actually that we've kind of been changing our definition of fully enrolled. But for these slides, it's just people who have signed the consent form. basically you can see what the enrollment rate is kind of overall. So we've approached over 400 families and enrolled about a little over 70. So it's kind of a slow process, and this just gives you the enrollment rate, which has been on average about 15%, though again, not all of that, them continue to complete the baseline survey and get a sample. So the actual enrollment rate in terms of getting data is probably going to be a little bit lower than that, which is similar to what we had in BabySeq, the first BabySeq project. And these are just kind of reasons for decline. And just to say that most people decline because they don't want to participate in research or they think it's going to take too much time. So there are all sorts of other reasons that are mentioned here, which there are many fewer families who kind of endorse. We basically ask every family if they say no, just why they say no, and just let them tell us. And then we kind of divide it up into, what the themes are. So it's really mostly a kind of a burden of research. And this is just the demographics of enroll. And the bottom line is that we're pretty successful in enrolling the individuals from the ancestries that we're interested in. So it has been mostly African-American, Hispanic families. And in terms of kind of patient education, it's, kind of varied here. You can see, though, that the household income, and the majority of them have a low household income. And certainly there's a number of them, or a kind of a majority of them, who are involved, who have that Mass Health or some kind of government plan. And then a majority also involved in a kind of the WIC program or the SNAP program to provides assistance for the infant. So we are kind of getting the socioeconomic and ancestry that we're hoping for in this project. And we've so far, our total, I think randomized, we've randomized 45. We've collected samples on 13. And we're starting to return results on 2. And this is a little bit not quite up to date, but it's just to say that it's been a lot of work over the past 6 months to kind of figure out how we're going to do this. And we've had to make changes and try to in kind of how we're approaching things. And it's been kind of a lot of work to try to increase enrollment, because we really our goal is to enroll 500 by the end of 2024. And so it's, as you can see from the numbers, it's somewhat of a challenge that we're working on. And I just wanted to kind of end by just looking really at how BabySeq informs the mission of the MBS-TRN. And so I think that, BabySeq really advances the understanding of the use of genomics to screen, diagnose, and treat conditions identified through MBS, and lays the foundation, we feel, for topics like consent, actionability of variants from all racial groups, as well as use of information over time. And I will kind of end there. This is our kind of the leadership team. So again, this Robert Green and myself are kind of the PIs of the whole project here at Boston. Carol Horowitz and Bruce Gelb, the PIs at York at Mount Sinai, and Bruce Korf at the University of Alabama. And this is our kind of whole team. Our primary funding is from the NCATS, the National Center for Advancing Translational Scientists, with some funding from the NICHD. We also had a grant through the Greenwell Foundations to do some of the interviews, and we have some philanthropic partners. So I will stop there and be happy to take any questions.
Thank you, Dr. Hom. And we do have a first question from Dr. Gelb in the chat, and I'm going to expand it a little bit. He asked you about the late onset pathogenic. What do you do? So I'm going to expand it. If you could just provide more information about how do you follow up with these patients? Do all families receive support?
So at this part of the question, I was asking Holly, about the type 1 diabetes, because we really have the same issue. The issue is one of, you have a grant that lasts for 4 or 5 years. You're identifying things that will happen later on, and how do you follow that? And that was an issue, the initial BabySeq project, and I think for us is kind of an issue for this project. And we wrote a grant originally to continue to follow the babies in BabySeq 2, but in our peer review process, it wasn't necessarily that innovative or, kind of, it was more kind of follow-up. And so it wasn't, it's the bottom line is it's hard to get funding for those kind of projects. So we do have in our consent form, believe it or not, that if when the child turns 13 or 7 or whatever, we would assent them. When they turn 18, we reconsent them with the kind of optimistic hope that we would still be following these kids for a while. But I think that's really part of what the issue is that, and I think this is for a lot of grants that are doing outcomes that are not immediate, and health outcomes are oftentimes not immediate. And so how do we follow them? It's a very good question.
I guess, can you hear me?
Yes.
Go ahead. Yep, we can hear you.
I guess more of the question is I believe that many for autosomal recessive diseases that, late onset pathogenic / late onset pathogenic is often not going to present ever. And so what will you report out late onset pathogenic / late onset pathogenic? Will you report that out knowing that in most cases it may never present? That's the biggest question I have for these programs is what to do with these cases.
Yeah, I'm not sure kind of exactly what, what particular conditions you're kind of thinking of, but essentially we are
pretty much any condition.
Yeah, so it's probably true. Yeah, so we are presenting, we have like 1,000 things on the thing. So anything that could be of childhood onset, we are returning. And so some things that could be of childhood onset are not necessarily will be of childhood onset, but that is what we are returning. So yes, things that could be of childhood onset, but most of the time are not, we would return, but we're not returning.
So that means the reason, because what I hear is that you'll be calling out pathogenic, likely pathogenic. And what I'm saying is that many pathogenic mutations are late onset, and you'll have many cases of late onset pathogenic. So I guess you won't be calling those out if you think it won't be childhood onset. Is that right?
Right. Yeah.
Okay.
We're returning things that are of childhood onset.
Okay. So
Yes.
even though they're pathogenic, that would be a case where you would not call it out.
We would not return it. No.
Right.
We're not going to return things that are the only exception, and I'm not sure I want to get into the whole thing, but it's what's on the ACMG. There's 2 things on the ACMG that are really considered just adult onset. So the Lynch syndrome and I don't know if it's Chamberlain syndrome and the BRCA, hereditary breast cancer, but we're not returning any other conditions that are really adult onset only.
So you wouldn't be holding the information in a patient's record, and if the disease presented later in life, the pediatrician, the PCP would have access to that information. Is there talk about that?
It's not reported anywhere. We don't report it. They'd have to go back to the sequence itself.
Okay. So you're not going to hold these maybe late onset cases?
No, we're not. We're not looking for them. They don't end up on a report. They don't end up.
Okay. That's the first time I've heard that, I think, from a next generation sequencing program.
Yeah, we're not generating a report that has everything on it and just choosing what to return. We just don't look for them. It's kind of filtered in a sense, in a way, to look for the things that are, that fit into our criteria. I'm not the person that's doing this. I'm in like,
okay. I understand.
Research,
okay.
So I can't tell you exactly how I've done it to Broad.
Yeah, because what I hear is we'll be calling out pathogenic only and ignoring VUS, but then that leaves all of these late onsets that are pathogenic, but right. There's another rule, and that you won't be calling out things that you think are not child onset.
Right. That's what I was trying to show in those buckets. The things that are adult onset, penetrance, whatever, we're not going to report anywhere. So
I understand.
they're in the sequence. So if somebody wanted to go back and reanalyze the data, they could do that, but it's not like it's a report somewhere that's hidden from view.
Right. I think this is the big, if you call these out, this is.
Mike, I think you're breaking up.
We're not really hearing you.
Mike. Can I add, I have 2 quick things I wanted to add to this discussion. First, I think this is an important thing to it's hard to know much detail to go into in presentations like this, but it is an important thing for the community to think about the approaches. So we are also using genome sequencing, and we're doing a similar approach where we're doing bioinformatic filtering. So the sequence is all being generated. We are only going to see, anyone will only see the results that we have on our panels, but the sequence is still there. And it is an important thing for the community to think through the relative benefits and harms. There are a lot of benefits to using genome sequencing. As Ingrid mentioned, it's much more flexible, and we can add and remove things, and we can go back and reinterrogate, but it does come with additional concerns. And so I think it's an important community discussion to keep thinking about. And the other thing did I forget the other thing I wanted to say? Oh, no, the other thing I wanted to say is related to what Mike says, which is a really important topic that we also need to think about. And part of why these studies are really critical is that most of you probably know, but most of the information that we have is from clinically ascertained families. And so it's critically important that we understand the phenotype. And, it's going to look different when we're looking at population-based infants. There is no question that we're going to find babies who have later presentation, milder presentation. And part of why we need studies like this is so we can figure out how to appropriately take data that has predominantly been gathered in the clinic and apply it to a population.
Yeah, the whole ascertainment bias issue. I mean, everything we've done, we've been doing has been in people who have the disease. And this is really an opportunity to look at also the various penetrants, because we don't really know. We think we know the penetrants, but we don't.
Yeah.
I think, Holly, we can safely assume that for many diseases, late onset will be a common genotype and will be a mild disease, right? We don't have to study that to death. I mean, right. I think that has to be sort of biochemically, it just logically has to be true. And so the number one question I have is what programs will do with that. And what I'm hearing is not report out, but on the table is maybe keep the information in case it's useful later. And that sounds like a smart move to me.
We're not even keeping the information, but it is possible families to interrogate. All right, I think we have, sorry, Jennifer.
We do have a few other questions. Yeah, I wanted to, I just wanted to wrap this up though a little bit, but it sounds like, and you guys can see if you agree with this, it sounds like most of the genetic sequencing programs, because they're not longitudinal, they're doing a research protocol, and then it looks like most of them are reconsenting them to be followed up under clinical care, not in the research protocol anymore.
Yeah, I mean, for us, they're not reconsented.
You're not following them long term. If there's something that you see,
exactly, and
it would just go into a clinic and be followed there.
Right. So the advantage of what we're doing is that we're enrolling in specific clinics, and so these are clinics that are affiliated with the institution that's doing the study. So I'm here at Children's Hospital Primary Care Clinic, and the kids are followed in Children's Hospital Primary Care. We're providing education to the primary care providers. We're here. They know that it's here. It goes into the medical record. It's a research result, but it goes into the medical record. And so that there's opportunities, funding or no funding, to follow those patients, because their primary care will follow them, and they're right here. So it is a little bit different than doing, I think what Holly's doing is more of a population-based study. Which is a whole different thing. And for us, even doing it at the baby nursery at the Brigham, those babies go everywhere. They're not followed in one place. So the advantage of this study happens to be that it's kind of confined, to one place in terms of where the babies are being followed.
Yeah. Okay. Whereas one of the things that we're modeling is how you actually do that handoff from what will be public health and now is research into clinical care. So, there are important studies that are structured differently and can answer different kinds of questions.
Okay, I'm going to try to get through a few more questions before I hit to the hour. Eleanor, I see your hands up. I'll open it up to you to ask your question.
Oh, great. Can you hear me?
Yes, we can.
Great. I have a question about the sample input that you chose of doing a blood draw instead of pairing the sequencing with like a saliva swab or dried blood spot that's part of the newborn's screening system already. And then part of my question about deciding on that is also the timeline of a 1 year old sample being accepted. Are you worried about not catching some of those more actionable conditions, you know, earlier, or even infectious things like congenital cytomegalovirus, which, you know, you would need to catch earlier in life rather than like a 1 year old? Can you comment on
Yeah,
that?
so first of all, we're doing, saliva doesn't work well in babies. We've tried it, it just doesn't
Okay.
work. We're not doing this in a, you know, these babies are born at a variety of different places. We don't have access to their blood spots. And the newborn screening program here won't give us their blood spots, so we can't use blood spots. We're actually using our ideal way is we're using microtainers, which involves doing a heel stick, and it's a micro sampling kind of technique that we're using. So that's, and
Okay, so it's not a huge EDTA tube that you're trying to fill.
no,
Really
not at all.
great.
No, it's like
I was thinking, I was like,
it's like a heel stick that goes into this.
okay,
And we collect it when the baby's in, you know, they enroll, they do the space and survey, we collect the sample, we send it to the brood. So there's no real delay. But saliva samples just don't work and we tried it, and particularly with whole genome sequencing, there's a lot of contamination from bacterial DNA. It just does not work well. So, and does that answer your question?
I guess also, why do you have it open so up until like 1 year of life? Why not pair it more with like birth of the like a newborn?
Well, we're doing this because we're going to clinics. So babies show up in clinic at, you know, whatever, like few weeks and 2 months and 4 months and 6 months. So we're pairing enrollment with the showing up in a clinic,
Okay.
if that makes sense.
Oh.
Not sure if that's answering your question or not, but that's how we're doing it, because we're not enrolling in a newborn nursery, because when we tried doing that, it wasn't a diverse population. And so we're really focusing on trying to enroll in more diverse population. And the way to do that is to kind of go where they are.
Okay, thank you.
And then Holly, your study though, it is, since it's population based, you are looking at the newborn period.
We wait until our state completes their newborn screening, because the last thing we want to do is disrupt newborn screening in the state. So it's a bit delayed from what would happen in real implementation, but delayed by a couple of days, weeks, or a month. We require enrollment by the time the baby is 1 month old. And the question that Eleanor raised about appropriateness of some of the conditions on the panel that have very, very early onset is a really good one that we have really struggled with. And it's a challenge because we don't want to miss, especially when there's a phenotypic range. And that goes back to that discussion we had last time, that we think that many of these conditions have a broader phenotypic range than we're aware of. So we've had a lot of discussion in our expert group that chooses our gene condition pairs about appropriateness of screening when the phenotype is extremely early, given that our results will not be returned until babies are weeks or a few months old.
And I should say, if we could work with our newborn screening program, we would, but it's just they just won't work with us, because that for us would also be ideal to use blood spot if we could. We're just unfortunately unable to do that. And I think the programs vary across the country in terms of willingness to participate in research.
Right, I think that would be a future ideal, because we already have so much of the newborn screening fleshed out. I think, isn't United Kingdom going to be doing a universal screening sequencing?
Yes.
Mm-hmm.
Yeah,
that would be amazing if we could.
Right, but we don't have national health care or essential. It's a whole.
Yep, really.
Baby Seek 2 and 1 and 2 are great first steps. We're good.
Yeah, so I know we're getting close to the hour, so I know Amy has been answering excellent questions about where the data is for the program in the chat. The Baby Seek 1 data is currently also been deposited, the genomes have been deposited in dbGaP. I do want to get to Kate's question. Kate, you also have your hands raised. We're going to see what, if you go ahead and you can unmute yourself and ask your question.
Sure, but we're at the top of the hour. I had a question for Ingrid, but I can ask her some other time. It was about actionability, and I feel like we can get into a very long discussion
Yeah.
about that too.
Why didn't you contact me separately just because I have a call that started a minute ago?
Yeah, I
too.
figured that you
Yeah,
need to
I'm
go.
happy to discuss offline.
Absolutely.
Well, I want to, before you both leave, I want to thank you again. Thank you, Ingrid, again for another lively discussion. Thank you, Holly, for joining this meeting as well, and your insight. This has been a very lively discussion from the both of you. So thank you for presenting. Hopefully we'll hear from you guys some even more updates in the future.
Yeah, thank you.
Thank you.
Thank you. If people are still available, I will give it like 2 minutes to just do a couple more announcements, and we understand if you have to drop off. I'm gonna open my screen to the so I just, oh, sorry. Oops. So I wanted to make sure that folks are aware to save their date. If Key Chan, Dr. Key Chan or Amy's on the line, they can unmute themselves. If not, save the date for our upcoming NBS Research Summit, which is September 13th and the 14th. That's a Wednesday and Thursday from 12 p.m. to 4 p.m. You should be receiving some more information coming out about that as well. And then also the latest addition to the podcast, our Newborn Spotlight podcast has been released. It's from Dr. Jerry Vockley on the role of medical genetics in newborn screening and genomic sequencing. Please join us. Our next meeting will be September 7th, and we'll hear an update from some of the sites that are doing pilot studies, and they'll give us an update on where they stand with that. So thank you again to any, if you have any comments or questions, concerns, please feel free to reach out to myself or Dr. Amy Brower. Feel free to share the link to this meeting. It will be posted on our YouTube channel with your fellow colleagues. And with that, I will say thanks again for joining, and I will close out the meeting. Thank you, everyone.